Hello, everybody, and welcome to the UVA Medical Center Hour. I'm Justin Mutter, Director of the Medical Center Hour, which is a program of UVA's Center for Health Humanities and Ethics. Today's event, the annual Jessie, Stewart, Richardson Memorial Lecture in the UVA School of Medicine, affords us an opportunity to turn to the ever-pressing question of quality, patient safety, and value in health and medicine. It's fitting that we come together today with this topic in mind as we celebrate National Patient Safety Awareness Week. This lecture honors the life of Jessie Richardson, a former school teacher who died tragically of adverse events in her care at UVA Hospital. It was in the spirit of Mrs. Richardson's commitment to education that her son, Dr. Don Richardson, in 1999 generously donated the funds on her behalf that have made this lecture series possible year by year. Such generosity and the many conversations it has catalyzed guide us all to be better, to improve our care and our systems continuously across time and space, all in the service of our patients. So today's lecture continues in this 25-year tradition as we look to the future of high-value medicine for our institution, for our region, and beyond. So a brief word about today's session, which is in virtual only format. When it comes time for questions from our Zoom participants, please use the Q&A tab at the bottom of your Zoom screen. I will relay these questions to our speaker during our question and answer time following the lecture. Also, just a brief word about continuing education credit for your participation. We are fully accredited to provide that continuing education credit, and you can see in the slides that began the presentation and also will be shown at the end of the presentation how to do that, but I'm just going to run through a couple of them right now. There are no disclosures for today's event, and there are multiple ways to claim credit. If you've got already have an account through the UVA CME online portal, you can do that. You can also text the code to this number. The code is the all-important information, and that is 27593 for today's event. So now I'm delighted to turn things over to Dr. Tracy Hoke, UVA's Chief of Quality and Performance Improvement, who will introduce today's distinguished speaker. Tracy.
Thanks, Justin. Today we welcome Barbara Markham-Smith, JD, who is an expert with 30 years experience in healthcare policy and healthcare transformation implementation. In her role as Vice President of Community Health and Innovation at VCU Health System, she created new partnerships to improve local community health. The partnerships created consistently positive returns on health system investment. She also led the effort to launch a federal primary care payment initiative to increase access to primary care and integrate care. She served as an advisor to the Health Innovation Consortium to foster technology innovation within the health system, particularly in response to the COVID-19 pandemic. Prior to coming to VCU Health, Barbara worked to implement components of the Affordable Care Act at the U.S. Department of Health and Human Services. Serving as founding director of the co-op program, she led the team that in 18 months established 23 new health insurance companies operating in half the country to advance competition in the health insurance industry. Before enactment of the ACA, she served as an advisor in the Office of Health Policy at HHS. She also worked as a senior health advisor in Congress during the Clinton administration in the effort to enact health reform. As a result of her work in think tanks and academia, when not in government positions, Barbara is the author of numerous articles and published studies on health reform. She graduated from Harvard College and Boston University Law School with a joint curriculum with the Harvard School of Public Health. She returned to her hometown of Richmond, Virginia, after living in Washington, D.C. for most of her career. She is married and has 2 children, and we welcome her today.
Thank you very much, Dr. Hogue. I appreciate your introduction. And I'm particularly honored to be talking today for the Richardson Lecture. Obviously, the devotion to quality is at the key of what we're going to be talking about today. So I'm just going to share my screen with you and there we go. Hopefully, oh, here we go. This is the best way. All right. There we go. To begin the discussion today. So we're talking about value-based payment in academic health centers and really looking at that as a pathway to quality for patients and clinicians. So how did we get to this fascination with value-based care and quality improvement? And it really came from, years of the evolution of healthcare reform and primarily the effort to expand coverage to attempt to get to universal coverage. It triggered a lot of interest in trying to improve quality so that patients were not put into what was referred to as a broken system. This extended right through the Clinton administration and their health reform effort, where the need to improve quality of care really took off and became a major motivation in the health reform efforts. And that's where we saw organizations spring up like the NCQA, the Leapfrog Group, the National Quality Forum, the Business Roundtable, the Washington Business Group on Health. All of these were largely business-driven to make sure that the expansion of coverage turned out to be a cost-effective, high-quality endeavor. And then came the Affordable Care Act. So this was a comprehensive approach to uninsurance, quality, public health, cost containment that was designed to operate synergistically to reduce the rate of growth in healthcare costs and improve health. And this led to the notion of value-based payment. And the Affordable Care Act was really the first effort a system of value-based payment into law, and it led to the creation of the Innovation Center at CMS. As part of this expansion of coverage, the focus on quality, the worldview really changed as well, and we became much more aware of the many factors that affected patient health. Obviously, social and economic factors, housing, poverty, food adequacy, health behaviors, the physical environment, genetic markers, and clinical care. And when we looked at the whole picture of what affects patient health, all of these other factors besides clinical care, you can see here that it represents 10% of patient-centered care, tend to overwhelm the clinical care that's provided. So it's not that clinical care is only important for 10% of the quality of a person's life, but rather that these other factors can completely overwhelm the impact of clinical care. So we've done all of these things. We've expanded coverage, we've put in innovative payment or started to implement innovative payment mechanisms. We've tried to contain costs. We've put a huge emphasis on quality. But where are we? Well, so where we are today is that 51% of the people with employer coverage skipped or delayed a visit due to cost. That's employer coverage is generally the best coverage in the country taken as a whole, the most generous, the lowest cost in terms of what the employee experiences. But we can assume that much more of those skipped visits has to do with the fact that employers are shifting more and more costs to employees. Then the employer costs have increased 20% over the last 5 years, hence the cost shift to employees. Access to primary care is declining. Social determinants of health, such as poverty, housing, food insecurity, lack of transportation, account for 50% of health outcome variation, which of course compels advances in health equity. Patients with a mental health or behavioral health comorbidity present double the risk of a hospital readmission. And substantial market imperatives and the desire to improve patient and provider satisfaction and business priorities have operated to change the way medicine is practiced. And this, business and employers are a huge driver of this phenomenon. So what is value-based payment? Well, put simply, the goal was to replace volume with value. It creates incentives to improve care quality, patient access, and outcomes, all of which are supposed to operate synergistically to reduce the total cost of care. It changes how care is delivered to minimize fragmentation and increase comprehensive coordinated care. And the notion is that in the end, comprehensive coordinated care reduces costs. It doesn't increase costs. So I know that you all have had some experience with the various forms of value-based payment that are now in the environment. You have an ACO, you've had bundled payments for joint replacement, bowel surgery, initially CABG surgery. Anthem has a QHIP program. All of these are designed to incentivize better quality, which in turn should lower the costs of redundant care, inadequate care, higher acuity care, and lead to better patient outcomes and better access to care. The expectation is that not only will patient satisfaction improve with these better outcomes, but that provider satisfaction and rewards will increase. Less frustration. So my thanks to Dr. Hoke for sharing this slide with me. This shows the recent incentive and penalty program performance within the UVA Medical Center. And as you can see, obviously, there's a lot of variation and some interesting patterns in this, but my purpose here today is to show the big picture, which is that you all had the potential to earn over $13 million from these various incentive programs, but in fact earned about $8,500. I'm sorry, $8.5 million. So you had $13 million opportunity and an $8.5 million harvesting realization. And what that means is that you left about 36% of the total rewards on the table. And it's not just financial rewards that are being left on the table, although obviously that's very important. But it also means that there was a failure to achieve quality goals for roughly 36%. Of the rewards, that there was a failure, and that if quality of care, quality metrics were in fact achieved, but it wasn't reflected, it means that there was a failure of documentation, which is not only important for actually earning the rewards, but it's also important in terms of what happens when patients are shared between different providers. That other providers are not seeing what the care was that was delivered and what the metrics showed. So there's a lot of opportunity here. And the question is, what do we do to get there? So here are the building blocks of value-based payment. And obviously, we think of this as the house of healthcare. At the bottom is the foundation, at the top is the roof. And I just want to emphasize a couple of points here. First of all, to start it, you have to have engaged leadership at every level. And obviously, that means engaged leadership at the senior executive level within the health system, but it also means engaged leadership at every level of care, at the level of care teams, at the level of chief residents. There is really, an opportunity for leadership at every organizational care point that you have. But obviously, it needs to start with senior leadership, and it needs to be based on a clear and shared vision and a commitment to support the investments that are needed. So robust data platform and analytic capacity. This is critical. I really don't know how you do this well without a fully functioning data platform that meets the needs of clinicians and that has robust analytic capacity. This means the ability to provide feedback, the ability to tell you what's going on with your patients, both individually and compared to other patients, the ability to communicate with each other, the ability to share information with all of the providers who touch the patient, and obviously the ability to just get information quickly that is relevant to the care that you provide. So I would say that these two elements are the critical predicates to proceeding. If you don't have engaged leadership and you don't have adequate, robust, analytic data capacity, then I think you shouldn't proceed. You just stop right there. Those are critical ingredients. It's like trying to cook without heat. So advanced primary care is the centerpiece of a robust value-based payment system. It is basically the way that providers can communicate with each other and with the patient, that they all know what's going on. Advanced primary care, and I know you have that here at the medical center, means that you have multidisciplinary staffing, that you also have a robust data platform, and that you have the ability to engage with your patients remotely. It includes the full integration of social determinants of health. This can really make the difference between rewards and penalties. You can't really be prescribing in a knowledgeable way for your patient if you don't know that they don't have a refrigerator in their home. Just an isolated example. Or if they're on the street, or if their housing is so inadequate that they don't have heat or clean water or other things that will be designed to sustain whatever it is that you provide. Clear and rationalized quality metrics and goals. So we talked about this in the context of the data platform, but your quality metrics do have to be integrated into the data platform so that you can get appropriate alerts and reminders that there are clear goals and that you know what the quality metrics are as you are treating patients. Close coordination between primary care and specialists within the medical center, externally, supported by IT, key ingredients of improving outcomes and being able to reap the rewards. The use of technology to improve access to care. This is really important, and it also implicates social determinants of health, because you have patients who have transportation barriers and they're not going to get the follow-up that they need unless there is a telehealth capacity to engage them. It also is important because if the more patients that can be appropriately engaged in mental health, in telehealth, the more patients that can be have their needs addressed to reduce redundant care or relapses, the more it opens up room to see additional patients. So as you're decreasing volume in recidivism, you're increasing volume in your ability to reach new patients. It's a really important concept. There need to be communication mechanisms between leadership and clinicians regarding the results. You are in, for example, a primary care first demonstration with CMS, with Medicaid. It's important for the clinicians to know that their total revenue coming in is actually better than it would have been if they had been in a strictly fee-for-service environment. That information needs to be communicated to ensure buy-in, and it also helps them understand that their patients are getting better outcomes through this. It's a really important motivator. So you have to be able to not only implement the system, but to sustain it over time. The distribution of payment between the medical center and providers in these reward systems clearly has to be ironed out. I know it's not a walk in the park, but it is essential. Once you have all of these things, everything in the pyramid thus far, you're ready for the roof, which is to get payers engaged in alternative forms of payment, such as more bundled payments, more episodic payments, fixed payments for certain types of care, so that you know that you can rely on what you're getting, and you know, since you have negotiated the fixed payment, that it covers a lot of costs which tend not to be explicitly covered in the fee-for-service payment system, such as clinician-to-clinician consultation, primary care provider and specialist consultation. You want to have it built in to your payment system so you're not worrying about it on a task-by-task basis. And again, only when everything else is put together are you in a position to approach the payers. So now the question is, how do you navigate this change? So academic medical centers have very specific challenges that are not faced by community providers. First of all, they have the complexity and uniqueness of their patient population. They have, which creates the reality that nominal adjustments to fee-for-service payments for quality, such as pay for performance, don't really compensate adequately for the complexity of the population and the complexity of the care that's provided. It puts a very heavy burden on documentation, which is going to exist no matter what. So you have to be prepared for that. But it's important that that heavier burden be met by better rewards. You have higher operating costs, obviously, as tertiary, quaternary, and educational institutions. There's a lot of absence of payment for high-value services. Again, for interprofessional consultations, for the case conferences, for all of the things that go on in academic medical centers, and for the guidance that are provided to primary care providers and patient management. The only way really to get that adequately compensated is through a non-fee-for-service form of compensation, i.e. value-based payment. A big challenge that academic medical centers are going to be facing more and more is that shared savings programs in which community providers participate incentivize them to refer to lower cost hospitals. And this is going to be proliferating, expanding across the country. Right now, there are many, many corporate organizations that now own large advanced primary care practices. You've heard of them: Privia, Premise, Centivo, all of these things, Marathon. All of these organizations engage in shared savings with their providers. And so the providers get rewarded pretty substantially at the end, provided that the patients, that they're showing that they are saving from the benchmark expenses. And the way that they can do that and have the biggest impact is to refer to lower cost hospitals. So the challenge for academic medical centers is to convince all of these practices that you are providing the best care, the most efficient care, the care that's going to save them expenses in the long in order to really be sustainable on a broad basis in the future. And another version of this is just the exclusion from narrow networks. Now, a big challenge that academic medical centers have is, I guess, the credibility to them of saying that primary care practices will be referring to less substantial hospitals. So to put it another way, faculty in academic medical centers have a lot of confidence in the dominance of their capability and their feelings of indispensability, which leads to a resistance to change, which is not constructive and doesn't help you get to the place where you want to be. It's not a motivator. And so the other problem with it is, it's really important, is that the indispensability may be overstated as community hospitals increase their capabilities without some of the larger infrastructure costs that you have. So here are some things to think about. Just as you're deciding what to do and what's important to you, there are a lot of things, both threatening and reinforcing, that should be going through your mind. One is that, as I've talked about, the declining volume of referrals due to existing value-based payment that's proliferating throughout the external markets and in commercial markets, is that as your volume decline, you get higher cost per patient because of your fixed costs. This leads to a spiral of per patient higher costs and declining volume, which then forces you into more rarefied specialization rather than the broader spectrum of care that you now provide, and ultimately a smaller footprint. This has real educational implications because most students and residents do not stay in academic settings. Among single degree MDs, most of them go into the community. And it's really important that academic medical centers remain as they are, the pipeline to more professional care in the community. I mean, you basically are the pipeline to staffing community-based care. And that's going to be hard to sustain if you are just doing rarefied, sort of magical results, and not training your learners in the most basic aspects of how to care for patients. The good news is that when you move to value-based payment, there's less reliance on quantitative metrics, which I know are a source of great frustration. I'll leave it there, a source of great frustration for clinicians. RVUs, time, exam room turnovers, limited time with the patient, and more time with attention to quality, outcomes, collaboration, figuring out how you get to the best results. The financial risk of improved chronic disease management, which means fewer procedures, fewer hospitalizations, that financial risk is actually improved with value-based payment because it provides better payment for outcomes, which offsets the loss of revenue to volume. And it also enables you to open up more access. So you get volume in different ways. Cost per patient go down, but you're able to mitigate a lot of those access barriers that exist in patient care today. And of course, it is particularly important as we move into a world of likely Medicare and Medicaid reductions, which make fee-for-service less sustainable, especially as you consider the share of your patients that come from Medicare and Medicaid. So let's think about strategic approaches for academic medical centers. We've talked about patient mix and acuity, nominal quality payments, no payment for high-value services. So let's start with the most obvious gorilla in the room, which is risk adjustment. Accurate coding really needs to be a priority for reflect risk that your patients experience and reflect. And this includes coding to reflect social determinants of health. This just needs to be integrated throughout your practice. And a word of caution here, and we could have an entire lecture just on risk adjustment and coding and how coding needs to be integrated into the care processes. But just a quick reminder that accurate coding is the goal, upcoding is not. Upcoding is considered fraud. So all of the complexities of medical care right in your risk adjustment. You should probably, to deal with nominal payments, you need to seek programs with higher rewards. Primary care first, which I believe is ending its cycle in 2025, has higher rewards than MIPS. That's just a fact. So, think about where you're putting your time and your investment. And obviously, if you're doing well in primary care first, the performance in MIPS or Anthem QHIP should automatically follow. Adopting episodic payments and warranties. Warranties are fixed contractual payments for a given body of service. No post-service reconciliation. It's a flat payment. Gets built in to those payments and is better reflected in the revenues that are received. Rationalizing quality metrics across services and bringing them to scale, leveraging investments on this across programs is really important for overcoming the silo structure of departments and divisions, but also in getting clinicians to internalize those quality metrics. So they're really sort of second nature, and having an IT system that automatically provides feedback on whether you're meeting those quality metrics. Increasing the focus on primary care and outpatient services also tends to break down the silos, because primary care providers should be, and you should be, communicating with all the providers that touch their patients. And that includes engaging in cohesive approach with teams and across teams through adequate IT platforms and direct communication. And then we need to pursue favorable public policy. So let's look at these things in orange over here. The cost of medical education, the cost of research, the need for academic medical centers to maintain more capacity for unknowns, to maintain their level 1 trauma centers. All of this is really a public good. It's a societal cost, and it has to be addressed effectively through public policy channels in order for AMCs to be sustainable over time and to sustain a broad spectrum of practice. So there are success stories, and important ones, around the country of AMCs that have engaged and been rewarded and successful in value-based payment. The list is here. In the initial years, Memorial Hermann was the #1 revenue value-based payment participant. Obviously, I know you all work with University of Pittsburgh, Montefiore Medical Center. I was at a conference where the CEO there said, we've changed our paradigm so that when we discharge people from the hospital, we say to them, we hope we never see you again. Meaning that because of our wonderful outpatient care and all of the outcome-based care that we provide, you don't need to be hospitalized. That's the goal. That's the goal. And obviously, you know, there are a lot of patients who will never be able to meet that goal because of the nature of their disease processes. But it's a different paradigm when you're thinking, we want to make sure this patient doesn't have to come back. So the policy agenda is in some ways aspirational. A lot of it depends on action by the General Assembly or Congress. But there are some things you can do as an institution that will help. While spreading the cost of medical education to all payers in a way that takes off the disproportionate burden that AMCs carry, that's very aspirational. I don't think we're going to see that in the next 2 years. So, but it's definitely got to be something that academic medical centers in a collaborative way are thinking about and as they develop policies. Spreading the cost of emergency and excess capacity, mass trauma events, pandemics, all of these things that you have to have the provider of last resort capacity for, that other providers are sending their patients to you. That's a public good. And that also needs to be spread. And that's a public policy societal consideration. Something that you can do on an institutional basis is to promote research funding mechanisms to improve effective value-based payment and better outcomes. There have been grants for this from HHS. There are a lot of private business foundations that are really interested in this. And it's very important to improving patient care and to learning new ways to deliver care that benefit patients and provide more gratification. As a result of that, I think it's important to create tenure tracks from people who engage in meaningful value-based payment research and are able to show implementation pathways to getting those new delivery practices in your healthcare system. So, you know, as much as we all value disease-related research and want to see that continue and grow, there needs to be a pathway for research about how we deliver care. Obviously, big lobbying endeavor is to sustain Medicaid and the ACA subsidy eligibility levels, so we don't experience a huge spike in uninsurance, which will increase costs for everyone. We also need to ensure that there's continued payment and for value-based payment to increase rewards, sustain longer-term savings, and create a pathway for sustainability for academic medical centers. And with that, I think we're ready for questions.
All right, well, thank you so much, Barbara, for that very wide-ranging discussion. I'm sure there are going to be plenty of questions coming in, but I'd love to just kind of get us started if that's okay.
Sure.
I was really intrigued by this this House of VBP kind of model that you had on one of your earlier slides, and I think sort of two challenges occurred to me. One is as we're kind of, you know, it seems like these are building blocks, like going up to the very top. So we really need to do all of them. And I think one challenge that sort of spins off of that is, of course, managing our sense of internal institutional psychological risk that
Right.
each of those rungs, right, on the ladder or parts of the house
Right.
are expensive because many of those things we haven't invested intensively in years past. But then as we're doing that and considering that risk, there's also this other part of it, which is budgeting. And
Right,
we're so used to, in large institutions, whether academic or not, we're so used to budgeting based on fee for service that
right.
we don't have great ways of accounting for cost avoidance or cost savings that help us manage that psychological risk as we're trying to do those things. So, how would you, how have you seen other institutions maybe engage that question, both on the sort of accounting side and on the managing our sense of risk with those initial investments?
Right, right. So, a really important multi-layered question. So I think that in terms of your sense of risk, one of the things that are really important to think about is how you can leverage existing investments. You don't need to reinvent the wheel. I think that you all have Epic, right? And did you move there fairly recently? When did you start your Epic journey?
We've had Epic for quite some time, and forgive
Oh,
me,
okay,
I don't have
okay,
the exact
2011.
okay. That's a good long time. Okay. So you want to see what, you want to do an internal analysis, probably with feedback from your clinicians of what capabilities Epic, your current system, has, and what it may have, but that is not being accessed enough or utilized enough. So you sort of need to do an internal audit to see what you can do to improve to leverage your existing systems. And then do an audit on what you are not getting that you really need to add to that system. Whether it's a quality metric alert or integrating the quality metrics into Epic so that a clinician can click on something and get immediate feedback. See how robust the analytics are within Epic. It's supposed to be its trademark. People are sometimes disappointed in that they're getting. So I would focus on building on what you have. Okay. You also already have advanced primary care internally, right? So, I think that there, again, it's not a new expense. It is an educational process to get the clinicians in primary care and the specialists to talk to each other more. And whether that's a communication capability within Epic or whether there are other ways to facilitate that, it's not something that's new. Now, you may need to enhance your social determinant of health capabilities. You may need to push that out from primary care and palliative care and population health departments into the system as a whole. But you've got a good starting point, and you're talking about incremental costs, not giant new capital expenditures, right? And then the goal of all of this, of course, is that you get rewards that reflect it. That's really important. So I think that's the way I would start. You have to remind me of the psychological thing is not just in making the investment. There's a big psychological leap in just collaborating more and embracing change. All of that is a psychological leap. And that really needs to be done in a collaborative way. Lots of communication with your faculty and care teams. It's an iterative process. And it's an educational process.
Well, thank you very much. Another question that's come through is asking about whether you could elaborate more on how the technology component specifically is essential to managing value-based payment. For example, telehealth and to other tech-based services that you would envision would help that process.
Right. So the tech, so I'm not a tech person, but I can tell you that the technology for telehealth in particular is important because you're getting paid for it, and who knows what's going to happen. But the budget deal that passed last night in the House of Representatives did include continued payments for telehealth. There, so that's good news. But it enables you to see more patients efficiently by creating access. An in-person visit just takes longer than a telehealth visit, in part because you're examining the patient and it's a longer conversation. But what telehealth does is it enables you to have follow-up so that you can tell if the patient is starting to experience problems, if they're not getting their prescriptions filled, if if they don't seem to be thriving, or conversely, that they're doing great, and maybe they don't need a certain intervention as much, or maybe, prescription dosage can be dialed back. All of these things contribute to better outcomes, and better outcomes are what value-based payment pays you for. So that's really important. It is definitely, as I said in my discussion, access to care for people who don't have transportation. Now, the key thing that your technology has to do is that as you're getting better outcomes, it has to be reflected in the documentation that you're providing, so that as you're providing data to a payer on your better outcomes, that technology has to be able to demonstrate that, to show that they had these visits, that these are their markers of good health, that they got to go home from the hospital. All of these things are very important to what I call reaping the rewards, harvesting the rewards. And you can't do it without the documentation that comes through better technology.
Thanks. Can you say a bit more? We have another question in the Q&A that talks about some of these incentives that are now coming out on the payer side, where if this individual mentions needing to get an MRI, but it happened to be a very specialized MRI and needed to be done at somewhere like UVA.
Right.
But instead, the sort of payer was saying, "Oh, you can go to these other places
Right.
for these reasons," and that speaks to your discussion about how academic health centers are increasingly finding themselves already engaging in this competitive space over value-based payments. So,
Right.
how have other institutions that you've seen or worked with navigated that increasingly competitive space? And what are some of those lessons learned?
Yeah. So I would say with great difficulty. But I think it's very important. This is where the primary care provider becomes an advocate for the patient. That's very important. And maybe working with the specialist to say, no, 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 we need this specialized CT scan. Or we need this PET scan, and something else will not do. And to try to do some internal research on how doing some quantitative analytics, basically, on how getting the right CT scan at the right time prevents duplicative care, provides the opportunity for more targeted care, and that the patient will have a better outcome. And you have to be able to demonstrate that. And maybe there's already literature that shows that, right? And in many cases, there is literature that shows it. And if you can hit them with some literature, that tends to force them off their intransigent position. But that's really, it's hard. And then at the end of the day, you want to be able to show Anthem or Aetna or Medicare that actually it worked, that the patient got well more quickly, had a more appropriate response, and that their total cost of care was less than it would have been.
Yeah, thank you. That's great. I was also intrigued by how you brought in the educational mission and linked it with the clinical mission when it comes to value-based payment, and not something that we think about super often. But
Right.
so I'm curious, as you've engaged that question and with other institutions or whatever, the degree to which there's interest in that from payers, because that's certainly something that's really important to any academic health center's mission, is sustaining that training mission.
Right.
And sometimes we find ourselves very much, we have to solve the clinical challenges. And so being able to broaden that umbrella to include all of our payers and supporting that
Yes.
mission would be truly amazing. So
Yes. So I can, a fair disclosure, I have a certain amount of skepticism about bringing about change within the insurance industry. Okay. And I suspect that skepticism is widely shared. But the initial visceral response from insurance companies is, oh, that's just going to cause us to increase our premiums, and God forbid we should eat a little bit of it, right? And just have, our profits reduced by 1/100th of 1%, But and their visceral reaction is always no to anything that spreads costs. So again, this is why it would be hard to do that on a one-on-one negotiation with an insurance company. This is why it takes action on the part of the General Assembly or Congress. And that's really where that activity needs to be focused. And you have to convince the General Assembly or Congress, and this one can be a tactic, but that it's going to reduce the total cost of care, that everybody benefits, that the care that you need to be sustained in the community, your academic medical centers, will become less costly, and the breadth of care that new professionals will come into the community with will be much better. But that's a lobbying mission for sure.
yeah, makes sense. Thank you. I think we have time for one more question, and this question is about the role of consolidation after the Affordable Care Act, and how that helps or hinders, depending on how we might look at it, the goals of value-based purchasing. So on the one hand, one might say that consolidation has the great benefit of providing integration of services. And of course, certainly we've seen in the last decade, even just tremendous purchasing of outpatient services by large health systems across the country. And so that provides that integration that one needs in order to do a lot of this great work. On the other hand, there's a lot of evidence that shows that consolidation increases prices. And so it would seem that, in the effort to be more engaged and competitive in the value-based purchasing space, those two things might butt heads against one another. So what are your thoughts on that challenge, and how we might, how all institutions might do that well?
Right. So it's kind of a paradox. The FTC, Federal Trade Commission, is no friend of provider consolidation. They don't seem to have the same concern about insurance company consolidations, but which also affects the costs of insurance premiums. But you know, I think that a lot of the systems that have been very successful in value-based care are pretty, you know, have a pretty wide footprint. And you know, you think of Memorial Hermann, you think of Brigham and Women's, you think of you know, Pittsburgh, for gosh sakes. I mean, Pittsburgh is a behemoth, right? And so I think that it is helpful to, in terms of quality and outcomes, to have medical practices that are operating on the same platform you are, with the same quality metrics and the same goals and the same delivery system habits, practices, that then get them engaged in a common mission. And so as they're delivering better outcomes, you're doing better in the value-based payment space. It's just important. You have to be a little selective, and you have to make sure that you're not getting increasingly redundant. In other words, you know, you want to do this in a way that discourages redundancy, I would say.
Oh, thank you. That's wonderful. And unfortunately, we're out of time, but I just want to thank you again for leading us in this incredible discussion, which I know we will continue to have across many weeks and months. And I want to thank also Dr. Tracy Hoke and Kathy Baker for supporting this fantastic discussion. I also want to thank again Dr. Don Richardson and family for this great Richardson lecture series. And lastly, but very importantly, Charlene Kaufman, our administrator for the Medical Center Hour, who always does a lot of wonderful work to make this happen. In 2 weeks' time, fortuitously, on Wednesday, March 26th, the UVA Medical Center Hour will welcome another distinguished speaker who will extend our conversation today in important ways. We will welcome Dr. Jonathan Perlin, who is the 7th President and CEO of the Joint Commission Enterprise, and he will speak to us on First Do No Harm, Then Do Good, a deep dive on sustainable healthcare. So we'll really be able to continue that conversation. This lecture will be held in person in the UVA Claude Moore Auditorium, as well as on Zoom. And for all of our participants out there, we hope that you'll be able to join us for that. Again, that's Wednesday, March 26th at our usual noon hour. Thanks again, everyone, for your participation today, and have a great week.
Thank you, and for such wonderful questions. Thank you.